Good evening, everyone. I'm very happy to announce today that we have two excellent speakers, as always, in Asia Society tradition. And today's topic is, how can India combat the second surge? I hope you are all keeping safe and well. My name is Firoza Godrej, and I'm a board member of the Asia Society India Center. I'm delighted to see members, patrons, friends from across the world join us this evening. For those of you who are joining us for the first time, the Asia Society is a leading educational organization focused on sharing knowledge and perspectives on international policy and business, education, technology, and the arts from across Asia on a global stage. Our mission is to share insights, encourage engagement, elevate regional voices, inform and educate new audiences, address complex and, where necessary, contentious challenges, engage in creative problem solving, and help deliver real solutions for the benefit of all. As a global network of centers who share a common vision, we actively collaborate with our centers and partners across Asia and the world. The Asia Society also provides its members an opportunity to become part of our global network to help shape a prosperous, sustainable, and secure future for us all. Since the onset of the pandemic in March 2020, the Asia Society India Center has been convening critical discussions on the public health system in India. We have hosted senior epidemiologists, virologists, and social sector experts who are currently on the forefront fighting the pandemic. We call it In This Together page on the India Center's website has listed some credible initiatives that are helping people in need. So I request you to please visit the website. It has also been heartening to see fellows from our Asia 21, the younger leaders, network and come forward to assist relief work in these critical times. As India continues to fight the second wave of COVID-19, we are overwhelmed by the plethora of information on vaccines, emergency use medicines, and preventive health measures. While this has significantly democratized the process of information dissemination, we are also left with several unanswered queries regarding vaccine efficacies, their effectiveness on virus variants, and inoculation. Through our discussion this evening, we plan to address many of these important questions. I'm really delighted, and I speak on behalf of the Asia Center family, to be joined by two distinguished health experts who will help us better understand India's vaccination drive and further ways to combat the second wave. Please allow me to introduce you all to our esteemed speakers. Dr. Zarir Udwadia. Zarir, I have been following you on so many platforms, some of which I don't know why I was there, but I was so interested right from the beginning, the Indian Medical Association, the Bombay Medical Association, to just give us lay people an understanding, and it has really, really helped. Ladies and gentlemen, Dr. Zarir Udwadia is a consultant chest physician, an MD, DNB, FCCP USA, FRCP London, attached to the Hinduja Hospital, Breach Candy Hospital, and Pasi General Hospitals in Mumbai. He has struck the unique balance of combining a busy clinical practice with internationally acclaimed medical research. He sees over 10,000 patients annually in his extremely busy clinics. He has published over 190 indexed medical research publications and was listed among the top 2% of respiratory medicine researchers worldwide in the field of respiratory medicine in a Stanford University publication. He has been advisor to the WHO Geneva and helped formulate TB and MDR-TB guidelines. In 2017, Open Magazine nominated him as one of their 25 top minds for his impact on public health. He is on the core committee of doctors elected by the Supreme Court to form a national task force set up to address critical nationwide COVID-19 issues like oxygen, drugs, vaccinations. I welcome Dr. Zarir Udwadia to this evening's webinar. And I also welcome Chapal Mehra, who is a public health specialist, writer, commentator. He works on issues of health, development, gender, and human rights. He has worked extensively with communities, the media, and civil society to advocate on key issues in health, particularly infectious diseases, mental health, addressing patient and civil society demands, improving access to early diagnosis and appropriate treatment, and providing economic and social support to patients and vulnerable communities. I welcome both of you to this evening's seminar. We are looking very much forward to hearing the questions and the comments. Just a little bit of housekeeping before we proceed. All those who are joining us on Zoom, please leave your questions in the Q&A box and not the chat box. And for our audience on Facebook, please drop them in the comments section. I would now like to invite Chapal to commence the discussion. Thank you very, very much, ladies and gentlemen.
Thank you, Feroza. And thank you to the Asia Society for inviting me. It's an honor to introduce Zarir and his work. We've been friends for a very long time and collaborators on many key issues. Over to you, Zarir. We're all looking forward to hearing from you. You're one of the finest minds in the country on COVID and on infectious diseases. Thank you.
Thank you very much, Feroza. Thank you, Chapal. Thanks to the Asia Society for this re-invitation. I spoke earlier on in the first wave of the pandemic, so it's only appropriate to be addressing you again. I hope you can see my slides and hear me clearly. Chapal?
Yes, we can. Please go ahead.
I will just start then. So we're going to speak about the second wave and the role of vaccinations. And this second wave really devastated this country of 1.4 billion. It also saw us become the very epicenter of the world's COVID crisis. Our infections pushed up to 27 million plus, our deaths to over 3 lakhs. And the pandemic sadly tipped 230 million Indians below the poverty line. Yes, it was inevitable, this second wave. It was unanticipated and unplanned for, however. It struck with a ferocity and velocity that would have, to be honest, taken even the best planned public health expert completely off guard. But it crumpled our weak and crumbling health infrastructure and really, in a sense, exposed our state of chronic unpreparedness. The wave sadly broke all records across the globe. We were the first country to cross 400,000 cases, new cases, in a day. And this grim landmark was repeated day after day for a week or more. At one stage, on the 5th of May, the daily cases in India crossed 50% of the world's total. Think of it, 1 out of every 2 COVID patients globally was Indian. The daily death rate was 1/3 of the global total. The highest daily death toll of any country, 4,500 plus, had never been beaten in 24 hours on the 18th of May. Our positivity rate stood at a record high of 20 to 40%. Positivity is how often your PCR is positive when you give a test. In the UK, at its peak, it was 10%. In the US, at its peak, it was 13%. We were consistently hitting 40%. At one stage in Delhi and in Goa, 50%, 1 out of every 2 PCR samples sent off to labs for testing came back positive. And sadly, 1,000 colleagues dead from COVID in India, as many as 270 in the brief 2 or 3 months of the second wave. And the actual death rates in red, remember, are at least 3 or 4 times higher than the recorded death rates in gray. And this is a consistent observation across the globe, not just in India. So there are about 7 to 13 million excess deaths worldwide in this pandemic, unrecorded, not listed as COVID, happening in the rural parts of our country where people die without COVID written on their death certificates. So we need to distinguish fiction from fact as when we look at Indian COVID data. We were concerned about 400,000 cases per day. The actual fact is that there are experts who feel this is closer to several million cases per day. That is the extent of underreporting suspected. Test positivity is close to 20% or 30% means, according to Ashish Jha, the dean of Brown University now, that you're probably missing 75% of all cases. And when we say the official death toll is 3,000 a day, actually, it could easily be 10 times that quantity. So we're looking at perhaps 25,000 deaths a day. On the 4th of April in Kanpur, for example, there were 4,000 excess funerals from normal, yet there were only 3 COVID cases reported that day. Just to give you some idea of the probable extent of underreporting. And these are the alarming positivity rates I spoke about in April and May. So this is what the trajectory of our second COVID and first COVID waves look like. The index case, of course, as you know, was a 20-year-old medical student who landed in Trichur, Kerala, on the 30th of January. She'd come from a strange place no one had heard of at the time called Wuhan. And the graph followed this trajectory. And you can see the first wave and the second wave nicely here. The first wave peaking in around late September, October. And even at its peak, the number of deaths, and we thought this was bad enough in the first wave, the number of cases, again, I beg your pardon, was about 100,000. There followed this lull, this window of opportunity, if you want, this latent period, if you want, when everything seemed to be quiet. And then, of course, this second wave, which took off, and now cases were closer to 400 or 500,000 every single day. Look at the speed of the 2 waves. In the first wave, you can see we moved from 1 million to the next 3 to 4, 4 to 5, in an average of about 10 to 14 days. So 4 million to 5 million was about 12 days, for example. Then there was this latent period of a couple of months when there were just 1 million cases. So putting things in context, and then there was the second wave. Ferocity was alarming, a very steep rise. And here you were seeing that you were moving from 1 million to the next in a matter of days. So look, from 30th April to 2nd May was all it took, 3 days to reach from 19 to 20 million. Now, how do the 2 waves differ? I'm not an epidemiologist. I'm a clinician who spent the last 400 days of my life looking after patients with COVID. So I can give you my clinical observations of the difference between these 2 waves, the first in blue and the second in red. There's no doubt, as you can all see, that this was more explosive and more virulent. That it was more infectious was also not in doubt. One index case, one case in the family resulted in far, far more secondary cases in the family, suggesting that this was a more infectious strain or variant. Tragically, younger people were affected this time. So people in their 30s and 20s critically ill, and I've lost people who were in their late 20s. I think this was a more democratic wave, if I can call it that, because the rich and poor were equally sickened, unlike the first wave, where it was more the poor. Worryingly, it did sicken and could sicken patients who had received 1 dose of vaccine, and we'll talk about that later. There was a greater need for oxygen in this wave and greater ICU need, as you're all aware, and I think it did carry a higher mortality. And sadly, we paid the price of ignoring history, because if there's one thing this pandemic has taught me, that it's that you need to look to the past to survive the future. The second wave of the Spanish flu, for example, a century ago, was far, far more lethal than the first. Our second wave started much later than the second waves in countries like the UK and the US, so we should have been warned. Yet I suppose we paid the price of hubris. We considered ourselves immune. Perhaps we were misled by these funny seroprevalence surveys. So we thought that we were immune or that large chunks of the population had reached herd immunity. We're miles away from herd immunity even now. And all these surveys were less than perfectly designed, in my opinion. This is from 1 century ago, but it looks uncannily similar. The first wave, the second wave, and what is to come, sadly. The Spanish flu, as you know, from 1 century ago, infected 1 of 3 people on this planet. It killed between 50 and 100 million people. No one is quite sure of the exact figure. It's known that 10 to 20 million Indians died. And we do know that the mortality was probably more than that from the First and Second World Wars put together. And you can see again here that the second wave of the Spanish flu lasted just 3 brief months, but was far more devastating than what came before or after. If you look at India's 2 COVID waves, the first wave was broader, lasting for 10 months, 9 million cases. This quiescent period, as I call it, and this steep, sharp surge in the second wave, 18 million cases and counting. So basically, double the cases in 1/3 the time is what the second wave has all been about. And then the consequences, sadly, were apparent. This virus cut a wide swathe across the country. Entire families were felled in all kinds of tragic permutations. Father, son, mother, daughter, 5 patients in one family dying within few weeks of each other. I know each and every one of you in this audience must have lost loved ones, friends, and family. Hospitals and healthcare facilities were stretched to capacity. ICU beds were impossible to get, no matter who you were, how important you were in Delhi at one stage, how politically connected, you could not get an ICU bed. Oxygen, that very elixir of life, was in short supply. Deaths from lack of oxygen in hospital sounds like an oxymoron, but it happened consistently across the country. This was not an exaggeration. And that's because our peak daily oxygen consumption at the peak of the pandemic went up tenfold to 9,000 metric tons per day versus 900 metric tons 1 year before. Essential drugs were in short supply, as Firoza has alluded to. There was black marketing, counterfeits. Scoundrels thrived on this opportunity. There was an epidemic of secondary fungal infections. And the vaccine program was characterized by, how can I put it politely, by lack of vaccine. This is from the dashboards of the Mumbai, Delhi, and Ahmedabad hospital nerve centers, and you can see there were just no ICU beds available in these 3 large cities and most other cities across the country. And sadly, now the virus is moving. This is a constantly shifting pandemic. Remember that. It's a patchwork pandemic, moving from state to state at different times. And it's now ravaging the north, the east, the south again, rural areas, which are sadly much less equipped to contain it. You tell me how this COVID ward in a small rural hospital in Bihar, sent to me from a colleague who works there, can hope to cope with the kind of surge that they will expect. Peak daily oxygen consumption, you can see these lines to fill oxygen cylinders of different sizes, 2 times baseline compared to the peak of the first wave, and 10 times baseline at the peak of the second wave. Hospitals closing down or refusing admissions because oxygen supply was not coming. And the reasons for this pandemic and the second wave were clear. It was a combination of complacency, of political miscalculation, a complete relaxation of all social norms, the slow vaccine rollout, and the emergence of variants. And then instead of using the precious period that January and February provided us, this quiescent period, as I called it, to ramp up on oxygen supplies, to stockpile essential drugs, to rapidly ramp up vaccination across all age categories across the country, to reinforce the importance of social distancing, of masking, we let down our collective guard. And now it's a battle between the vaccines and variants. We allowed the variants to emerge, of course, and they are the greatest single threat to control of the pandemic. They could potentially derail the success of vaccines internationally. Remember that viruses mutate, and the SARS-CoV-2 is no exception. In fact, it is not a very rapidly mutating virus. The influenza virus mutates much faster. It mutates about once every 10 or 11 days. But variants are multiple. But when a variant becomes a variant of concern or is classified as a variant of concern, that is when it becomes dangerous. And there are 4 just now, only 4 across the globe. And you're all familiar with this: the UK variant, the South African variant, the Brazilian variant, and sadly, the latest, the India variant. And you can see that all genetic samples or genotypic samples are given to this broad data repository. And you can see that the Indian variant, the 1.617, has rapidly become globally, across 40 countries, one of the dominant players. In fact, on April 1st, it accounted for 80% of all genome sequences sent by India. And here I need to add that India is woefully backwards when it comes to sending genetic samples or analyzing genetic samples for variants of concern. So the virus is always one step ahead of us. This is the so-called Indian variant, the B.1.617. It looks grotesque, and it is. It has 2 mutations. Actually, it has 15 mutations. So double variant is not quite wrong, is not quite correct, rather. But these are the 2 important mutations, one which escapes antibody detection and one which confers increased infectivity. And so I would argue that the development of vaccines against a novel virus, which we didn't know existed till a year ago, must rank as mankind's greatest scientific achievements. But delivering billions of those doses worldwide will prove the greatest logistical challenge. And we know why vaccines are so useful. Why are doctors asking all of you to vaccinate yourselves in a hurry? Because we know that they prevent severe illness, prevent hospitalization, and really should be preventing death across all comers. But the race is on between the vaccines and the variants, and for humanity's sake, the former should win. So COVID vaccines, we have currently 12 deployed and in use across the globe. 70 are in phase 3 trials. More than 175 are in preclinical or clinical trials. And the biggest vaccination drive in the history of the world is underway. As we speak, 1.6 billion doses have already been delivered across 176 countries. But bear in mind equally that inequities exist, and several countries across the globe have not begun to vaccinate their populations. We are vaccinating people at a rate of 28 million doses a day as we speak, every single day. These are the 12 vaccines actually being deployed and in use currently. And I've put flags against the countries that have developed them, and America has 3, China has 3, and we have 1, the indigenous Bharat Biotech developed Covaxin. And this is from the World Vaccine Tracker from 2 days ago when I checked. The darker the shade of green, the more the vaccine rollout across the population in that country. And as you'd expect, it's the dichotomy between the rich world and the developing world. So Europe and America are doing much better than anywhere else. And if you zoom in on India, as of 2 days ago, we had given 193 million doses, which sounds like a lot, but it sadly covers just 7% of our population and 3% if you talk of 2 doses. And you can zoom in at a country-specific level, and I've put up some of the success stories like Israel, like the United Kingdoms, like Germany, in contrast to India. And I guess we can take vicarious pleasure in pictures from the UK, where people are back to life as normal. Pubs have opened, concerts have started, sports events and football matches have started, and you can see the picture is completely different here. So the real world impact of the vaccine in any country where it has been rapidly scaled up and rapidly ramped up, I understand that these are smaller countries considerably than ours, but the real world impact is obvious, is apparent in terms of the number of cases coming down, the number of ICU beds not being required, the number of hospitalizations coming down. The Pfizer jab, for example, cut all admissions across Scotland by 85%, and the Astra jab by 95%. Imagine if we had rolled this vaccine out in our country, what we would have been at present. In contrast, our drive has stuttered and stumbled, and really it's gone horribly, horribly wrong. So why this slowdown in a country which was hailed 6 months ago as a vaccine superpower? I think it boils down sadly again to planning or miscalculation. The two local vaccine manufacturing powerhouses were not given advance payment or directives by the government about the number of doses they needed to produce. Simple math would have told you that for a country of our size, we would need about 1.3 billion doses. Essential raw materials proved difficult to acquire, and there were holdups in the vaccine production process. International orders for foreign vaccines were just not placed. Call it nationalism, call it what you want. Pfizer, which was keen to enter this country a long time ago, was given a hard time because of indemnity clauses, insistence on local trials, and this is probably the most effective vaccine we know in the world. Vaccine diplomacy ensured that doses were distributed with generosity abroad, at one stage more abroad than used internally. When the vaccine rollout began, there was a reduced perception of threat because we were going through that latent period I described. So everything was very slow and sluggish. There was initial vaccine hesitancy, and sadly that's been replaced by vaccine desperation, as all of those of you in this audience who've tried to get a vaccine now know. There was a fear regarding side effects, doubts regarding efficacy of the vaccine, death by WhatsApp, as I put it. A misfiring app did not help, and of course it excluded most rural Indians who did not have access to smartphones. And of course, this was the insoluble problem, a huge population which needed to be vaccinated in a hurry. What we did get partially right, and I congratulate the government on, is that with South Africa at the WTO, we demanded on a waiver of vaccine patents, though we did not insist on a corresponding transfer of technology. Look, waiver of vaccine patents is one thing, but even if Moderna and Pfizer allowed us to duplicate, we would not have the know-how, even with our smart scientists, because making mRNA vaccines from scratch is extremely difficult and demanding. The indigenous Covaxin's intellectual property rights were not offered to other Indian manufacturers. This is a more simple heat inactivated vaccine, which others could have scaled up if we had planned in advance. And so sadly, we have these crowds at vaccine centers, which are serving as spreader events, super spreader events. And we are a long, long time away from herd immunity, my friends. The US is just 98 days away, and you can see how restaurants and bars have opened up. That's 70% population vaccinated at the current rate of their program. And this is the sorry picture we cut. We are about 4 years away, which is dreadful to contemplate if we continue at the same speed, of course. The crucial question, the million-dollar question in my mind, is whether the two available vaccines are going to work on the variants that are circulating through our communities. This is a complex subject. The good news is that we think that they will protect us, at least from severe disease. We hope that they will protect us. The bad news is that we cannot be sure because we do not have enough data. We don't have enough data on the circulating variants in this country. We have sequenced less than 0.1% of all our strains. The UK, in contrast, has a huge £20 million project funded by the Wellcome Trust, where every single day variants are mapped across the country, so they're always one step ahead. All I can say as a clinician is that I have several patients who are critically ill after the first dose of vaccine, and sadly, a few who are dead despite 2 doses, including healthcare workers, but that I would grant is extremely rare. We've got very, very preliminary data suggesting Covaxin and Covishield both work against Indian variants, but these are all in preprint form, and I eagerly await the actual publications. And this came out just today from Public Health England saying they were highly effective, the Pfizer and Astra vaccines against the India COVID variant. And I'm going to end now because we need about half an hour and we have exactly that for discussion. I'm going to end now with this quote from Tony Fauci, who said, We need to get as many people vaccinated with the current vaccines that we have as fast as we possibly can. That's the bottom line, isn't it? And we need to prepare for the potential eventuality that we might or will have to update our vaccines sometime in the future. So that is the end of my brief presentation. I'm going to stop sharing, and I look forward to my discussion with my old friend and colleague, Chapal.
Thank you, Zarir. It's wonderful to have you make this presentation, not only because I think it's one of the most comprehensive, nuanced, and sensitive presentations that I have seen on the COVID epidemic in India, but I think it also points to solutions, which we often, in this climate of gloom and despair, often forget that we need solutions, we need immediate action. The country has been sort of horrified by the images that we've seen over the last several months. And as you rightly pointed out, there was this whole period of complacency, or rather relaxation, where we thought this epidemic was behind us. But many of us who work in public health knew that it was far from over. We've been receiving a ton of questions, and since we have limited time, I'm going to just jump right into them. A lot of them concern the second part of your presentation around vaccines. The role of vaccines and vaccination is critical in this pandemic. But there is so much confusion around what vaccine to take. And from vaccine hesitancy, like you rightly pointed out, we have come to vaccine desperation. Can you share your thoughts on what we should be, how people should be thinking about vaccines, what vaccines should they be taking?
Chapal, if I had a penny for each time I was asked which vaccine should I take, I would be a millionaire several times over by now. My answer is always the same. My answer is take the first vaccine you can access and take it as rapidly as you can. If you ask me between the two available vaccines in this country, for example, available as of now, I hope that we will have more options as time passes. But of the two available vaccines we have now, which one would you choose? I would say they're both equally effective, equally safe. So don't hesitate. Take the first vaccine you can access is the message. Don't window shop. This is not the time for that.
Thank you. Thank you for that, because I think that's very critical that people recognize that they should get the first vaccine that they can get. But, Zarir, India is also this huge country of comorbidities, right? Everybody has, in many ways, has some underlying health issue. There is a lot of panic. I've heard many people talk about how they shouldn't take the vaccine because they have an X problem or Y disease or, a chronic illness. Now, who should not be taking the vaccine? Because a lot of people are just self-excluding.
Yeah, and that is so sad when you see someone in the ICU and you check with the family and you ask, didn't he take the vaccine because he's 75 years old, he's diabetic, and you get the same response, no, he was a bit scared to take it. It is really tragic. So there are very few people where you would say, don't take the vaccine. And I'll tell you who my list of just 3 is. You wouldn't take it when you're having any acute illness, of course. So if you've got malaria or dengue or anything else, you wouldn't take it. You wouldn't take it during active COVID, obviously, or soon after you're recovering from active COVID. And most important, if you are allergic to any of the constituents of the vaccine. I don't care if you have food allergy and drug allergy and you almost had anaphylaxis with penicillin or sulfur, or you almost choked on a tomato. If you are allergic to any component in the vaccine, then do not take the vaccine. But otherwise, there is no one who should not be vaccinated. Certain groups of immunodeficient patients need to take special precautions, maybe fine-tune their drugs before they actually take the vaccine. But basically, the vaccine is safe and recommended across all comers. So I hope we can spread that message here today.
The other question, related to vulnerable populations is about pregnant women, women who are nursing, and children. I mean, this is a huge area of concern because pregnant women are not going out there and getting the vaccine because they feel it'll harm their fetus, it'll harm their pregnancy. And of course, this is also true of nursing mothers, and also they're fearful about children. So can you shed a little bit of light on that?
So, Chapal, it's interesting you asked because this week's issue of the New England Journal of Medicine has the largest publication of pregnant moms, 35,000 plus, who received one of the two messenger RNA vaccines. So they received either the Pfizer or the Moderna vaccine. And gratifyingly, they found a number of things. They found that the vaccines were safe in pregnant women. Of course, they will need to follow them up carefully when we talk about safety. They found that the pregnant women did elicit good antibody responses. They found that the antibodies crossed the placenta and therefore also helped the fetus and protected the fetus. And the vaccination, the antibodies induced by the vaccine also passed across breast milk in lactating mothers. So this was really good news, but we need, again, similar vaccine studies in pregnant women with the two vaccines available in our country, and we don't have those as yet. But I would say it is safe in pregnancy, though you have to keep, obviously, your antenna wide open for any signals of toxicity and side effects.
I mean, we're talking about children, so I'm going to ask you this question. This is something that a lot of viewers asked us, people who are attending the webinar long before soon after we announced it, which is about the impact of the second wave and the third wave on children, right? There is this huge panic because we started by saying, oh, it doesn't affect children. But we're seeing something different now, aren't we?
I want to say that we shouldn't underestimate the impact of this pandemic on children. The profound impact of 1 year away from school, of 1 year away from friends, from the playground, is bound to impact on their development and long-term impact on their development. And the good news is that, at least in Israel and the US now, the vaccine is being rolled out to the 12 to 18-year-old category because they have vaccinated all the adults they need to. And I do know that Pfizer has started trials as of a few days ago in the 2 to 10-year category. So we're talking of toddlers. And look, Chapal, this is the only way to open up our schools again, to get our children safely back to schools without worries that they will infect their parents or grandparents when they return. And indeed, I do think that vaccinating children is the only way to eventually reach herd immunity or step up the process to reaching herd immunity. It is speculated, but we cannot be sure that the third wave, and sadly, we are not done when we talk about the second wave. So now we need to get our preparedness up a gear, surely. But it is anticipated, though not proven, that the third wave might hit the children especially hard. But that remains hypothesis. And I know the Maharashtra State Task Force, which I'm a part of, is particularly focusing on preparedness for this group.
The other thing that I did want to ask you, and this is something some of our viewers also have questioned. Now, it's becoming clearer that despite all the random statements that are coming out of various quarters, science is the answer. And in science, particularly early diagnosis and vaccines, well, vaccines most importantly. But how do we counter? Because in India and in other countries, there is a plethora of misinformation. There is talk about side effects. There is talk about you will always get COVID. I mean, there is a real sense of vaccine hesitancy. I mean, I know friends in our circle who say, I will wait and see when a better one comes along. How do we address this vaccine hesitancy? 2 or 3 suggestions. How do we counter this misinformation?
And, vaccine hesitancy and anti-vaccine sentiments are not India specific, as you know, they're global. And your level of income or your social status or even your educational status, interestingly, does not correlate with your views on this particular topic. For example, France must remain the most vaccine skeptical country in the world, because consistently when people in France are asked, would you take a vaccine if it is available, 40% of the population will say, no, I won't. In the same poll, for example, 16% of Indians said they wouldn't. So we are a more trusting people, perhaps. That's good to know. But how do you counter this? The answer is simple, like you know from our TB work, the answer is education. The answer is perhaps to have a few well-respected vaccine ambassadors, people who are universally trusted and loved, to come out openly and publicly saying that they've taken their vaccine and would urge everyone to do the same. And I think, to be honest, fear and the fear that the second wave has generated is now responsible for the huge lines outside vaccine centers when there were none, sadly, when the vaccine drive started in January.
Um, Thanks for that, because I think that's a very critical point to make, that you cannot just have the vaccine. I mean, there is a vaccine shortage today, but actually vaccine hesitancy in the initial period did slow down uptake. The other question now that has emerged, which is, I think, a burning question for most people who've taken the first dose or are planning to take the first doses: can I mix up the vaccines? There is a lot of talk about, can you take a second dose of Pfizer? AstraZeneca has limited efficacy against the current Indian variant. I don't want to use the word Indian variant, but the variant that we are battling today. What are your thoughts on that? Can we actually mix up vaccines? Is it possible?
So this is an age-old immunological concept called heterologous prime boosting. That when you combine two different vaccines, in fact, the Sputnik model is based on two different adenovirus vectors, but generally when you mix two vaccines, you often get a better response. And there is a study in Spain called CombiVac, combining vaccines, as the name suggests, which is actually putting this to the test. An initial dose of the Astra vaccine, followed by a dose of the Pfizer vaccine, two completely different platforms, a viral vector platform and a messenger RNA platform. And the results are very interesting. We have some preliminary data, which was out in preprint form, and they showed that the antibody response that you got as a consequence of this mixed approach was double that you would get of giving two doses of the same vaccine. So there might be some joy and mileage in combining two different vaccines. And I'm sure that we will see trials along these lines if we can get two different vaccine developers to work together, ever that is. But this is clearly something of interest. I'd also like to say that people ask, should I take a third dose of vaccine or a fourth dose of vaccine? And the answer is, at present, we do not feel it's safe to take more than two doses. Almost certainly you will need a booster, like you need a booster for the flu vaccine. And wouldn't it be wonderful if vaccines eventually convert COVID, a dangerous, potentially lethal disease, into a more benign flu-like illness because of what the vaccines have done over the years. And this virus is never going to go away ever, but this is the hope, that eventually with vaccines, we will convert it to something no more alarming than a case of flu.
I mean, I must take this one question, because I think I have about 8 questions in the Q&A box asking the same thing, which is 2 doses. What is the ideal time difference? And Mehru Kotwal has asked that, RN Verma has asked that. I mean, a ton of people have asked this. What is the ideal time difference between, and I'm assuming they are talking of both AstraZeneca and Covaxin, and also how does the efficacy vary if the time difference changes? Because that's what we are being told currently.
So that's a very good question, and I knew this would come up. So basically, the initial study from out of Astra said that 4 weeks was the ideal dose. A small subgroup of patients in this study, by serendipity, not by design, happened to get their vaccination later than that, really because of a mistake in the trial design. And this was a small subgroup. And they showed, look, this group mounts an even better antibody response. Now, it was in the public interest to seize that, really, when you wanted to vaccinate more of the population. So I think that was partly what drove the recommendations from out of the UK initially to space out the dose between two vaccines to as much as 8 weeks, and then even beyond that. Just the idea being that you spread a thin resource as widely as you can. Having said that, there are recent studies which show that one dose is just not enough. That your second dose really is the crucial dose in getting adequate immunity. If you asked me, all things being equal, vaccine stocks being uninterrupted and profuse, I doubt we'll ever see that day. But if you ask me, then what would you choose, or when would you choose to get your vaccine? I would say 4 weeks to 6 weeks. And while the UK now, recognizing that the 2 doses, the second dose is so crucial, have brought their time period downwards again, we are sadly going in the opposite direction, really because we have no choice, because our vaccine supply is so thin. So it all boils down to how much supply you have. Okay, your antibodies may be slightly more if you space it out, but do you want to really risk contracting COVID in that crucial time period between the first and second doses? as so many people do. So I hope I've answered that clearly.
No, no, you've answered that very well. And I think the about 8 or 10 people who've asked that question will really appreciate that, because that is a genuine concern in India. People are being turned away because they're being told you've not completed the 12 or 16-week in between. The other question that a lot of people in India are asking, and I think elsewhere too, is what about those who have survived COVID? I mean, when should they be getting the vaccine? At what point will it have impact and efficacy that is required?
So a lot of Indians have survived COVID, obviously. And look, generally, COVID for most people is a mild illness. It can often be asymptomatic. The treacherous part of this disease is that it is so very unpredictable. You come in looking great, you wonder why the patient is in hospital. 2 days later, the patient is on the ventilator, a young patient. And the old father or mother goes back home. They came in together. So, what advice would you give regarding vaccination or when to vaccinate people who've recovered from COVID? You follow the current CDC guidelines, and I think the Indian government has also recommended that it should be a minimum of 3 months. Why not earlier? Because there's no rush. You have plenty of antibodies, good antibodies, for at least 3 months, possibly 6, 9, or even longer. Even if your antibody levels are low, your whole T cell system is primed. And there's a very low chance of getting a second episode of COVID. If you've actually had COVID once, it serves you better than any vaccine can. But then there is the fear of the variants, the fact that antibodies levels will eventually dwindle and decline. So I would stick to the recommendation of 3 months after you got COVID before you take your first dose of your vaccine.
Thanks, Sari. One of the things that's feeding vaccine hesitancy and, in a sense, denial also is a lot of people, and you mentioned this in your presentation, do get COVID after the first dose, and some of them also after the second dose, right? We are seeing some of those cases as well. Now, in such a scenario, what does how should people conduct themselves? Because a lot of people get one dose and feel that, there are all these news reports, I'm 70% immune, I'm what are the chances of getting the infection post first dose and post second dose, and how does it help us?
So great question again, Chapal. Let me first give you Western data, because that's what we need to rely on. Sadly, we don't have good data coming out of our country still, although most of the cases are being generated here. So there was a large study from San Diego which showed in healthcare workers, which showed that getting COVID after your vaccinations was extremely rare. It happened in 1% of a group of several thousand, I can't remember how many, healthcare workers who had been vaccinated but were followed up serially, 1% only. And most of the cases occurred in those who had had just the one dose, but there were some, and a small minority, that is, in those who'd had two doses as well. In the UK, a study showed that there were just 4% of hospitalized patients, 4% of patients who ended up in hospital had received both doses of the COVID vaccine. Look, that's what the vaccine is supposed to do. It's meant to keep you out of hospital. It's meant to keep you out of ICU. It's meant to keep you from getting severe COVID at least. But again, sadly, you are right. We are seeing, and we did some back of the envelope calculations at one stage at the peak of the pandemic, we saw that 25% of all the cases I had admitted under me had received their one dose. Many were getting it soon after that one dose, probably contracting it at crowded vaccine centers, which were serving as super spreader events, as I said. So they took their first dose and got it 5 days later. Now, that's got nothing to do with the vaccine. But even 4 weeks later and 6 weeks later, and I have lost doctor colleagues, sadly, tragically, who've had, and in Delhi as well, who have had both doses of the vaccine. And that is the really frightening scenario, that even 2 doses of the vaccine may not protect you. So the important message, Chapal, on how we should be handling ourselves is to never forget the importance of masking up, of social distancing, not letting your guard down collectively or individually, even after you've had the second dose. The biggest variant of concern, as someone quipped, is not maintaining 3 meters distance and not wearing your mask at all times. So I see that we will be wearing our masks for the predictable future, or it's wise to do that anyway, despite large chunks of the population, or when large chunks get their 2 doses.
And which is also quite a distance away from us, quite a time away from
You
us.
said over 3 years at current rates.
Yeah, I mean, we have a few vaccine skeptics even here, and I wanted to pose this question to you because I think she's raising a valid point for some skeptics. Priya Agarwal says if the vaccines are not effective against the variants, really is even the 4 years to herd immunity or herd immunity at all possible? And why should one bother vaccinating
No, that,
ourselves, really?
that Priya is an extremely cynical view. We don't know. We don't have enough data on the efficacy of the vaccine on the variants. In fact, the last slide I showed you was that the AstraZeneca vaccine, and there is initial research from the Covaxin as well, showing that they do work across the variants. Maybe they're not as effective. It stresses the importance of quickly getting your population up to herd immunity before a new variant comes across. But not taking the vaccine, saying it's not going to work, is not the right attitude, because they certainly give you more protection than going unvaccinated. We need more data, more granular data, as I said.
A very important issue that I want you to address, which has become a talking point in the public, in the media, is this phenomenon of black fungus and white fungus, and and there is panic. There is not enough scientific perspective and clinical perspective on it. Can you please speak to the audience about that? Because I think that is very, very critical.
So black fungus is the word that or the phrase that the lay press has seized upon for this extremely rare fungus, or it was an extremely rare fungus prior to COVID, called mucormycosis. The term is a misnomer. It's not a black fungus. As you said, it's a white fungus or a gray fungus if you were to see it growing on a culture plate. It's called black because once it infects human tissue, it moves at such devastating speed that it leaves behind a trail of death, basically. Black is necrotic human tissue. And these are the most grotesque pictures of faces and orbits and sinuses eaten away by this fungus. And sadly, it is an iatrogenic disease. It is an epidemic which is following a pandemic solely in our country, solely because we have such poor prescribing practices. It is being caused by the industrial doses of steroids we are throwing at our patients. Steroids have to be used very, very judiciously. They should not be used at home in the early stages. They should not be used in patients who do not require oxygen. They can actually make things worse. They should be used in the right dose for the right duration. If you do not agree to those guidelines, this is a devastating consequence. They also occur in people who are diabetic, and this combination of diabetes, and India has the highest diabetic population in the world, as you know, plus the steroids, is what is causing this pandemic of mucor. And again, we're caught off guard because we don't have the vital drugs, amphotericin, for example, to combat this. So again, we're quickly panicking and trying to get stocks when it's too late.
We're in the last 5 minutes. I'm just going to take two questions, and I'm going to ask you an important ending question. One of our friends, Anand Grover, is asking this question. Do you agree that the decision of the central government to go by the national immunization program and procure only 50% of the vaccine centrally and leave the balance to be procured by the state and private entities is a disaster? I mean, I think what he really means to ask is, will this work in this current situation? And if not, what are the other issues that we should think about?
Anand is old friend and lawyer, so I have to be very careful when I answer. But Anand, you're right. I agree with you completely. This is to vaccinate each and every Indian and do it free of charge, I think is a responsibility of the central government. And I think it's wrong to put up our hands, for them to put up their hands and now almost leave it to each state to fend for themselves, as we've seen is the policy at many stages of this pandemic. I think that is the least we can offer a poor villager, even in Uttar Pradesh, at least a free vaccine. It is incumbent on the government to be doing this, according to me.
Another question that has come from across the border, and that's why I want to pick it up. It's come from Karachi by Yusra Askari, and it's an interesting question. They ask, Dr. Udwadia, RT-PCRs aren't able to pick up the mutation of the Indian variant. I think the question more broadly is, if the RT-PCR is not picking it up, how many cases are we
I don't think the RT-PCR does not pick up the Indian variant. The RT-PCR anyway has an inherent problem in that it's not 100% sensitive to diagnose COVID in general, but there is no evidence that it would not specifically be picking up the Indian mutant.
Another question that we have actually from Khurshid Ichaporia is about what is your opinion of the rapid saliva test deployed in the USA after approval by the FDA? Would that test be helpful in rapid diagnosis?
It's a reasonable screening test as the US and Europe opens up their borders. It's so rapid that within half an hour you're waiting outside a restaurant and you can have your test result come in, but it's not sensitive and specific enough for us to be adapting it on a wider scale.
Yes. I mean, I think one of the questions now that I want to ask, because we're in the last 3 minutes, and I think it will take you some time to answer it. You and many others like you have been on the front lines of this pandemic. You have seen this evolve. You have seen this grow, abate, and then rise again very, very closely. You've seen it both at the clinical level, but also how it has devastated populations, communities, and families. I want to ask this, what do you think India and countries like India, I don't just want to make it about India because the South Asia region can be very badly affected, should be doing immediately, in the medium term, and in the long term to cope with what is happening right now and the upcoming third wave, or whichever wave we want to call it?
So Chapal, you're asking me my bucket list if you want.
Yes.
So I'll tell you what I think. First and most important is to rapidly vaccinate every Indian using every available effective vaccine as rapidly as possible. And as I stress, this is a responsibility and onus on the government and one that it owes each and every Indian. Then, of course, we need to address our chronic infrastructure issues. We must ensure that no Indian dies because he does not have an essential drug, or more tragically dies because he does not have access to oxygen. And wouldn't a wonderful silver lining from the gloom of this pandemic be if we move towards universal health coverage, for example, across our country? Thirdly, I would say that we need to encourage responsible evidence-based treatment guidelines. We've talked about this, for example, for our other passion, tuberculosis, how bad prescriptions fuel the rise of TB. And equally, we are seeing dangerous prescriptions, and we saw the example of mucormycosis and the black fungus. I do believe that many of our currently available treatments do more harm than good for COVID. And we really need to have strict guidelines about what we should be prescribing and what we should not be prescribing. We need our ICMR to step up to the plate and deliver more in terms of its research. We need more gene sequencing. We need to be one step ahead of this virus, not 5 steps behind as we've always found ourselves. And finally, we need to improve our pitiful underinvestment in public health. Less than 1.5% of our GDP, sadly, especially in rural countries. I dread what is going to happen as a poor village, as a small district, which relies on oxygen cylinders, Chapal, encounters this wave in our poor people. How will the doctors cope? Where will the facilities be? Forget remdesivir. I mean, they don't have beds and they don't have oxygen cylinders. We have the lowest doctor-nurse bed ratio of the group of 20 countries. And all these dreadful health inequities have to be addressed. And if some good comes out of the pandemic, it will be if these are eventually addressed.
I think that's really a very helpful and positive note to close on. I've already been told that we're going well ahead of our time. I cannot thank you enough, Zarir. I know you are very, very busy, and a whole hour today answering all our questions has been very helpful. And I hope it will urge and sort of motivate more and more people to sort of get vaccinated, observe COVID appropriate behaviors, and also help each other, because I think one of the things that we have discovered during this pandemic is the importance of science, but also the importance of empathy for each other. So
thank you. It's always a pleasure talking to you.
Same here. Thank you. Take care, and look forward to another one of Asia Society's interesting discussions. Thank you all.